Hello, everybody, and welcome back to the main stage. So I hope you all had a good break. We could see that there were around 35 of you with Chris in the Writing for Publication session. I hope that really does provide you with some really good advice about publishing in Nursing Children and Young People children's journal for nursing in the UK, and I hope that you are all going to keep Chris busy with lots of submissions. I nipped into some of the some of the other sessions, the networking and the exhibition. I didn't realise that the networking was working like professional dating with a 3-minute introduction to somebody, so I might do that later and come and meet some of you. So welcome back. It's a huge privilege to introduce David Green, who is nurse consultant for immunisations from Public Health England. Following a varied nursing career, including general medicine, cardiothoracic ICU, and infection prevention, David became an immunisation coordinator in Calderdale in 2008. He's been nurse consultant for immunisations with the National Immunisation Team at PHE in 2014. David completed an MPH at the University of Leeds in 2014 with a dissertation on the efficacy and safety of pneumococcal vaccines in the elderly. So nothing more for me to say, but welcome, David. Thank you very much for taking the time to come and talk to us today. I'm sure you are hugely busy considering where we are with the pandemic and the rollout of vaccines across the UK, which I have to say, from someone who's had 2 doses, has been the most amazing experience, and just fantastic to see what the NHS can achieve in such a small amount of time. And even better than that, the day after my immunisation, I sat with my GP for a consultation, and he was able to tell that I'd had my immunisation the day before and what type and what time. The infrastructure around this is absolutely breathtaking and such a huge commendation of what we're able to achieve in the health service. So welcome, David. Everybody, there is an opportunity for questions. So please do again post questions in the Q&A section, and we'll have 15 minutes with David to talk those through. Thank you, David.
Thank you. If I could have the first slide, please. Thank you very much. I think before I talk about this slide, I'm just going to pick up on something that Dave said in the introduction, which is about the rollout of the COVID-19 vaccination program, because the rollout of that and the uptake, I think, has been absolutely astonishing. Ballpark figure of about 26 million doses of vaccines given in the routine immunisation programs in England each year. And the COVID vaccination program in England surpassed that level after just over 100 days of vaccinating. So if you've been involved in any way at all in vaccinating staff or members of the public, like myself, I've had my first dose with COVID vaccines. Thank you and well done, because the mobilization of services and the pace with which the program has rolled out has been truly astonishing. So I'm going to start with the routine childhood vaccination program. I'm not going to go through all of these different vaccines and diseases, but the point of this is just to set out the stall, really, is that from birth up to adolescence, we're very fortunate in this country to have a comprehensive immunization program, which brings great benefit to individuals and to the wider population as well. I think we protect against something like 14 different diseases. It kind of depends on how you choose to count them, because we protect against 5 different strains of meningococcal bacteria and 13 different strains of pneumococcal bacteria. But it's a very, very comprehensive program. The routine program starts when babies are 8 weeks of age, and in that bottom box, you can see there that actually we've got some targeted programs as well. So if a baby is born to a mother who is infected with hepatitis B virus, then there is a an accelerated course of hepatitis B vaccination for those babies, which is important to try and prevent vertical transmission. And also there's a targeted program of BCG vaccination depending on where in the country that baby might be born or where its parents or grandparents were born. So we're very fortunate that to have such a comprehensive program that helps keep children and young people safe from sometimes serious and potentially life-threatening vaccine-preventable diseases. Could I have the next slide, please? By way of illustration of that, this is an infographic that illustrates the reduction in some vaccine-preventable diseases that we've seen since their introduction. I'm not going to go through them all, but some of the more recent ones, for example, I'm struggling to see on my own screen here. We introduced the vaccine against meningitis group C in 1999, and we saw a 97% reduction in the incidence of that disease. And some of the older vaccines, for example, if we go back to measles, which was introduced in the 1960s, again, we've seen almost 100% reduction in the incidence of measles in this country. And I will be talking a bit more about measles elimination later on in this presentation. So the population, both the population of children and adolescents, and by extension through indirect protection, others who are too young to be vaccinated or perhaps too old to be vaccinated or not part of the program, also get indirect protection from the vaccines that children get. That's particularly true of the bottom one there, the pneumococcal vaccine. When we started vaccinating babies against pneumococcal disease in 2006, actually what we saw was a reduction in the incidence of serious pneumococcal disease in adults as well. So that vaccine is good enough to protect the child, but it also means that the child isn't carrying that bacteria and then passing it on to their parents or grandparents, for example. So a very comprehensive and successful program. Could I have the next slide, please? Although this conference and this session was talking about children and young people, I felt it was important to perhaps start with preconceptual and maternal vaccinations. So if we think about rubella, it's a live vaccine, it's part of the MMR vaccine, it's live, so we don't give it to pregnant women. So generally it's better given in a preconceptual situation. We're fortunate in the UK that we still have rubella elimination status, but we need to maintain high uptake of MMR vaccine to maintain that population level protection, because rubella is really quite an infectious disease. It's easily spread. Despite the fact it's been eliminated from this country, we still see sporadic cases. So the WHO definition of elimination of a disease means that there's no ongoing transmission taking place in that country. That doesn't mean to say that we don't see the occasional case, and very often those are imported cases. So between 2010 and 2016, we saw 13 cases of rubella infection in pregnancy in the UK, and some of those led to babies having congenital rubella syndrome as well, which is the disease that we're really trying to prevent. That's the whole purpose of giving rubella-containing vaccines. So it remains important that individuals who lack 2 recorded doses of MMR vaccine should be caught up. And that's particularly important to check those records and offer those vaccines to individuals who are not born in this country. Some of the cases, in fact, I think the majority of cases of rubella infection in pregnancy that we've seen have been in women who were not born in this country and for reasons unknown haven't been vaccinated on admission to this country or on registration with a GP. So it's really important that all pregnant women are immune, all women rather of childbearing age are immune to rubella. We also offer pregnant women an inactivated influenza vaccine each flu season, and that can be given at any stage of pregnancy. We're really trying to offer a triad of protection here. So we're trying to protect the pregnant woman because flu infection late in pregnancy can have serious health consequences for the pregnant woman. We're trying to protect the fetus because we know that influenza infection in pregnancy can lead to miscarriage. It can lead to low birth weight babies as well. And there's also benefit for the newborn baby through passive immunity, through transplacental antibody transfer. That remains important, so that the baby is born without suffering the ill effects of influenza infection in its mother. And we also offer a pertussis-containing vaccine, a whooping cough vaccine, to pregnant women from 16 weeks of gestation, ideally between 16 and 32 weeks, because we need the antibodies in mum to build up. And again, what we're looking for is this transplacental antibody transfer, so that baby is born with passive protection against whooping cough, which can then be changed, if you like, into active protection against whooping cough through the routine vaccination program, which starts at 8 weeks of age. And we've got quite good uptake in that program. We give the last 2019-20, which is the last full set of data that we've got, showed 70% uptake. Could I have the next slide, please? I'm not going to go through all of these line by line because it's rather a busy graph, or chart rather, but if we look at uptake of children's vaccines in England, going back to 2012, 2013, generally what you see, certainly in that first column there for the combined vaccine, what we call the hexavalent vaccine at year 1, because it's got 6 antigens in it, is that it started to decline after 2012, 2013, and various measures were put in place. And what we saw in 2019-20 was the green shoots of recovery. We started seeing vaccine uptake going up a little bit, and we started to see that pattern being repeated in the first quarter of 2020, 2021. We were very encouraged to see these improvements in vaccine uptake after some years of small declines. And then what you can see in quarter 2 and quarter 3 for 2020, 2021 is that we've now got some declines, and we suspect this is the COVID pandemic effect adversely affecting uptake of childhood vaccines. If I could have the next slide, please. This is rather a busy slide, but this is some work that colleagues in PHE have been doing to look at potential effects of COVID pandemic on uptake of childhood vaccines. So this is the 6-component hexavalent vaccine that we would normally give at 8, 12, and 16 weeks. And you can see the dotted lines are dose 1, 2, and 3 in 2019. And I think what you can see fairly clearly there is then the solid lines for 2020 are showing decreases in uptake for all 3 doses of that hexavalent vaccine, and they seem to start going down shortly after the starting points for social distancing. I think I'm slightly encouraged when we look at the slightly thinner line with the dots on it for 2021. Actually, I think we're starting to see a little bit of improvement, particularly with dose 3 from about February, March time. It looks like that is coming back up a little bit. So I'm encouraged by that, and I hope that that this is parents perhaps being more willing and confident to bring their babies forward for vaccination, and also the hard work of general practices and general practice nurses in particular in making sure that previously unvaccinated children are being caught up. If I could have the next slide, please. Similarly, we've looked at data for the uptake of MMR. The first dose is normally given just after the first birthday at 12 months of age. So we've measured it at 18 months of age in 2019, 2020, and 2021. And you can see there the solid blue line uptake of the first dose of MMR in 2020 did actually start to decline compared to 2019. And if we look at the limited data we've got, which is just the first 3 months of this year, actually, I think what we're starting to see is perhaps a very slight increase in uptake, all of which is very welcome. Measles in particular is a very, very transmissible disease. It's far more transmissible than COVID. And we need very high uptake levels of MMR vaccine. We need 95% coverage for both doses to eliminate measles transmission. So there is still some work to do there, but pleasing, I think, to see perhaps the green shoots of recovery, and hats off to all those practice nurses out there who are catching up these children who have missed previous doses of MMR vaccine. If I could have the next slide, please. So I just wanted to share with you the results of a study that was done by Sadie Bell and her colleagues at the London School of Hygiene and Tropical Medicine. They did some attitudinal work of parents, what their views and experiences were of routine childhood vaccinations during the COVID pandemic. And vast majority of respondents, 85% of them, still considered it important that their children receive routine vaccinations on time and on schedule, even during the COVID pandemic. But they did identify some barriers. Some parents felt there was a lack of clarity as to whether or not those vaccination services were still operating as normal, and that was particularly more prevalent, or that feeling was more prevalent amongst lower income households and black and minority ethnic respondents. And some reported difficulties in actually accessing and organising vaccination appointments. And there were some who feared that even that they or their children might contract COVID whilst they were attending general practice. So I think those slight decreases in vaccine uptake that we saw in the first two slides probably, whilst there is correlation on those slides, I think what this presents is probable causation, is some lack of confidence about bringing children forward for routine vaccinations during the COVID pandemic. If I could have the next slide, please. I've mentioned measles a couple of times earlier. So in 2017, the World Health Organization declared that the UK had eliminated measles. And what that means is that there's been a 12-month period where measles has not been transmitting in this country. It might still be possible to see the occasional imported case, but that hasn't led to clusters or outbreaks of measles. But unfortunately, that elimination status has not been maintained. In 2018, we had a marked increase in the number of confirmed cases of measles, with 991 cases in that year compared with 284 in 2017. The strain was this B3 Dublin strain, and that was detected for more than 12 months across the UK in 2017 and 2018. So unfortunately, based on that data, the WHO determined that the UK was no longer considered to have measles elimination status. And we're working with colleagues in NHS England and the devolved administrations and the Department of Health on a measles and rubella elimination plan, because we need to re-establish our measles elimination status. And part of that, of course, is driving up uptake so that hopefully we get 95% uptake for both doses of the MMR vaccine. Could I have the next slide? I'm going to switch slightly, and we'll talk about the adolescent vaccination programs and the impact of the COVID pandemic on those. As you know, the the COVID pandemic has led to schools being closed, and that has a major impact on the ability of school immunization teams to access children, because things like the diptech polio boosters and HPV vaccine are given in schools. Schools closed, they had limited access to those children. Some areas, and this is one of them in that image there from Derby, some areas did drive-through clinics. Others managed to use school premises and then invite the pupils into those premises. Others set up clinics in, church halls, village halls, town halls, that kind of thing, health centres, to try and keep some sort of immunisation programme going. And hats off to them, because I think their efforts have helped to maintain not exactly optimal uptake, because they couldn't do that because they didn't have optimal access to the target population. But as we'll see on the next couple of slides, I think the work they've done has been highly useful and very commendable in terms of keeping these programs going to some extent. So could I have the next slide, please? So we give 3 vaccines routinely to adolescents. There's the tetanus, diphtheria, and polio booster, otherwise known as TDIPV. We give men ACWY, so this is meningococcal bacteria. We're vaccinating against groups A, C, W, and Y. And the one that we're particularly interested is the group W. This is a hypervirulent strain of meningococcal bacteria that has an increased risk of mortality should you get it compared to other strains, and an emergency program vaccination was introduced in 2015, and I'll come on to talk about that a little bit more on the next slide. And we also vaccinate against HPV, which is the human papillomavirus. It causes genital warts, but it also causes anogenital cancers, in particular cervical cancer. And you can see there for all 3 of those vaccination programs, previously, prior to the COVID pandemic, we were comfortably achieving mid to high 80% uptake for all 3 of those vaccines. And then in 2019-20, unfortunately, because of the impact of the COVID pandemic and schools closures, we haven't seen quite the same uptake. But I'm hugely encouraged by the fact that we're getting sort of high 50% uptake. And this is due to the sterling work of the school immunisation teams that have managed to keep services going wherever possible. I think the other factor that I didn't mention on the previous slide isn't just about lack of access to the target population. A lot of these teams are redeployed. To help out with the response to the COVID pandemic. So that, I think, also had an impact on services. You'll see there the table in the bottom right-hand corner. This is showing HPV first dose in 2019-20 in year 8. And I've split that into males and females. And the reason I've done that is because that is the first year that boys were included in the program as well. And I'm pleased to say my youngest son is one of those boys who got his first dose of vaccine at that time. And generally, I think uptake in males is not too far off uptake in females. And from a population level point of view, we were very pleased with that. We were pleased to see that almost similar numbers of males are getting vaccinated against HPV as females. So if I could have the next slide. I spoke just now about the this hypervirulent, very nasty strain of MenW, and this is a graph which shows the total number of cases in each of the epidemiological years, which run from July to June. So you can see there that in 2010-11 and 2011-12, that actually we were getting quite a number of cases of these virulent strains of MenW. The emergency program was introduced in 2015, and we've been vaccinating teenagers and university entrants routinely since then. And then you can see in the years subsequent to that, that actually the cumulative number of cases in each of those years has started to decline. We've got a limited amount of data here, but for 2018 and 2019, for the first 2 months of that, which is that little red line in the bottom left-hand corner, then you can see that actually we've started to kind of flatten that curve quite a bit. And that's the effect of the vaccine. So I'm going to give another thank you now, that if you're a general practice nurse or a school immunization nurse and you've been jabbing teenagers with men ACWY vaccine, thank you and well done. We are suppressing meningococcal disease in this country by virtue of your efforts. So thank you and well done. Could I have the next slide, please? In a similar way, this is a graph showing the prevalence of HPV strains 16 and 18. These are of particular importance on a population health level, because these are two of the strains that cause anogenital cancers, and they are the two main strains. Between them, they account for the vast majority of cervical cancers, for example. And you can see there that since we started vaccinating females against these strains in 2008, and we did a huge catch-up program, went right the way up to from year 8 in school up to year 13 in school, that you can start to see there that actually fewer people, fewer young women are infected with those cancer-causing strains, and that will eventually start to show itself as fewer cases of cervical cancers as these women get older. So again, thank you and well done if you've been part of that program and if you've been vaccinating against cancer-causing HPVs. Could I have the next slide, please? And the next one. I was going to just touch on the COVID vaccination and COVID infection in children and young people. This is a graph that's in the Green Book. The Green Book is our guidance handbook on vaccination against infectious disease. There's a new chapter in there, chapter 14A, which talks about vaccination against COVID. It's available online. If you just Google the Green Book, then you'll be able to bring that up. And I think what's interesting here is if we look at the second to last column on the right-hand side, the one that says infection fatality ratio percentage. And if you go to the bottom half of the chart and you look at that by age, actually what you can see that this data is showing that 15 to 44-year-olds, it's just naught. There is no fatality ratio there, but then it goes up quite considerably as you look at older cohorts. So that's an important point to bear in mind. Could I have the next slide, please? So the single biggest risk of mortality from COVID infection is increasing age, and that risk increases exponentially with age. And we saw with the COVID pandemic that particularly we saw high number of cases, and we saw high case fatalities in elderly people, particularly if they were in care homes. So the risk of mortality is higher in those aged over 65 than that's seen in the majority of younger adults, even if those younger adults have underlying health conditions. So current evidence is suggesting that children and young people have a very low risk of COVID-19 and very low risks of severe disease or death due to infection with that virus compared to adults. So the COVID-19 vaccines are not routinely recommended for children and young people under the age of 16 years. There is a slight exception to that, and that is children who have got severe neurodisability, who may be more prone to frequent respiratory tract infections and have to spend long periods of time in residential care settings because of their complex needs. they are recommended to have the vaccine. That's current advice. I know that there's an awful lot of talk or there is some talk in the media about whether or not we're going to give boosters or whether or not we're going to vaccinate children. There are no policy decisions on these yet. These are all issues that are being examined, and we expect more information on this to come out in the future. But that's the current situation where COVID vaccination and children are concerned. Could I have the next slide, please? One of the reasons why there is low uptake of vaccines is often people will say, oh, you've got a hesitant population. There's a population there that don't believe in vaccines, or they don't think they're safe, or they don't think they are necessary. And in 2019, the World Health Organization included vaccine hesitancy as one of its top 10 threats to global health. And they've defined vaccine hesitancy as a delay in the acceptance or refusal of vaccines despite availability of vaccination services. Vaccine hesitancy is complex and context specific, varying across time, place, and vaccines. It includes factors such as complacency, convenience, and confidence. So could I have the next slide, please? And in the next few minutes, what I'm going to be doing is talking about some of the data that PHE have around attitudes to vaccinations. These next few slides are contain unpublished data, so please don't take copies of them. Please don't screenshot them or share them because this is as yet unpublished data. So we have data from a tracking survey from early 2020, before social distancing was initiated. 1,800 interviews of parents of children aged 0 to 2 and then 3 to 4. And in 2018, we also did a teenage survey where we asked some questions of teenagers themselves and of their parents as well around their attitudes towards vaccination. So could I have the next slide, please? This is one of the questions we put to the parents of infants about their confidence in vaccination programs. And you can see there that the vast majority of parents of infants are either very confident or confident about vaccination programs in the UK. Could I have the next slide? This slide shows whether or not parents kind of stop and think and weigh up the advantages and disadvantages before proceeding with vaccination, or whether or not they are happy to proceed on the basis that vaccination is necessary and that it's safe and it's the right thing to do. And I think what we can see here is that actually there's a bit of a divergence, which is what we want to see when we're asking these sorts of questions. So what this suggests is that confidence in vaccination amongst parents of infants and young children is increasing, their concerns are decreasing, and generally they're seeing it as part of routine healthcare for their babies and for their children. So we're quite encouraged by those data. Could I have the next slide, please? We also ask questions about trust in sources of advice about immunizations. I'm not going to go through all of these rows, but I think the top two are of particular interest. You can see there that parents either strongly agree or tend to agree in large numbers that GPs, practice nurses, and health visitors are trusted sources of information about immunizations, as is the NHS, held in very high regard. These were taken before, these questions were asked before we went into full lockdown, and they're consistent with previous year's data as well. So it's really encouraging to see that key healthcare workers and the NHS as our kind of national healthcare brand are held in high trust by the parents of young children. Could I have the next slide, please? Just a couple of slides on the results of when we asked similar questions to either teenagers or the parents of those teenagers about whether or not they've seen or come across anything that might make them concerned or worried about having a vaccine during their teenage years. You can see there that the vast majority of parents and young people don't have any particular concerns. Perhaps they've still got concerns about the kind of things that perhaps are understandable, such as side effects, and they don't like needles and bits and pieces like that. But generally, they're quite accepting of vaccines. Could I have the next slide, please? And similarly, we ask questions about who they trust advice given by when it comes to vaccinations. And the parents and the teenagers, again, are very trusting of the advice that they receive from health professionals and from the NHS, slightly less for government, but they are particularly trusting of yourselves as health professionals. Could I have the next slide, please? Okay, almost there. So I think what the data shows is that the COVID pandemic has disrupted routine vaccinations for children and young people. And there is evidence that uptake of vaccines for children and young people has declined a little bit during the COVID pandemic. NHS England, the commissioning teams, the public health commissioning teams in NHSE are working with provider organisations to make sure that children and young people who've missed their vaccines are caught up. The schools vaccination programme, there is an expectation that catch-up will have been completed by the end of August this year. We're going to carry on doing further studies into vaccine uptake data, because they're really important to understand whether or not those catch-up programs have been successful, and whether or not we need different strategies in the future to target children and young people who may have missed those vaccines, particularly I think for MMR. We've got generally, I think, high levels of confidence in immunisation programs for children and young people, but I think we still need to be mindful that some people might still have specific concerns relating to the relative risks and benefits of routine vaccination versus the fact that we're still in a COVID pandemic. It's important that routine and targeted vaccinations are given on time. However, it's never too late to get vaccinated. So any child or young person who, for whatever reason, has missed a vaccine, if they're still eligible, and they probably will be, it's important that that vaccine is still given. And I think one of the key messages here for this audience is that nurses and health visitors are trusted professionals, and I think they're well placed to counsel parents and young people as to the benefits of vaccination and how to access those vaccines. And then could I have the next and final slide, please? I just wanted to share with you some immunisation resources. So we've got a collection on the PHE webpage, all sorts of information on there about the routine schedules, about the infographics showing the benefits of vaccine, links to the Green Book, links to uptake data, training resources, patient group directions, etc. Vaccine Update is a free monthly electronic communication from us in PHE out to anyone who has an interest in immunisation and vaccination, and that I think now has something like 58,000 subscribers. There's also the Value of Vaccines programme, and there's a link to that there. Health publications is something that comes up relatively frequently. So PHE designs, funds, makes, stores, prints, and distributes free of charge to vaccination providers all the leaflets and posters that help to promote the immunisation programs. There's no need for these to be, in most cases, downloaded or printed off locally. The vast majority of them are available free of charge via that health publications web link there. And finally, the Vaccine Knowledge Project. This is something that's run by Oxford University, and I think it's fantastic. It goes into quite a lot of detail around the safety and the efficacy of vaccines. And I think if you've got parents who are asking questions, quite detailed questions about vaccines or their contents, then actually there's quite a lot of good information in the Vaccine Knowledge Project. So that concludes my talk. Thank you very much to the RCN for inviting me. Thank you very much for the attendees to logging on today and listening to me. And I think, are we going into questions and answers now, Dave?
Brilliant. Thank you, David. That was such an informative presentation and some really interesting findings from some of the data that you've got there. So brilliant. Thank you very much. We do have some questions and comments. The first is a comment from Pamela Tomlin, who says, thank you, this is really interesting. I think we need to acknowledge the role of health visitors in increasing immunisation rates in the under fives. I don't know if you just want to comment on that before we move on.
No, I completely agree. You'll have seen from the data that health visitors are a trusted. Sorry, the cat is just drinking my water. Excuse me. The joys of working from home. Health visitors, again, a trusted profession by the parents of young children. And no, I completely agree, Pamela. I think that the advice that health visitors give to new parents around the benefits of vaccination is very, very important indeed. So yeah, good comment. Thank you.
A question from Lara Parker, and you may or may not be able to comment on this. She asks, can you comment on the occurrence of severe side effects from vaccinations, i.e. blood clots associated with AZ? So that's the AstraZeneca, okay. I think, isn't it?
Yes, the AZ COVID vaccine. I probably don't have a huge amount to add over and above what MHRA and JCVI have given us public statements on the government website. So the incidence of thrombosis with thrombocytopenia is very, very small for the number of vaccines that have been given. The medicine's safety surveillance that takes place after the introduction of any new medicine, including vaccines, I think has been very, very important, and it's great that we've got good functional systems and yellow card reports that healthcare workers and the public can fill in. That has shown this very small risk of blood clots and thrombocytopenia after what we think is the first dose of the AZ vaccine. And that's why there are now additional recommendations about whether or not, for example, you would give it to somebody under 40, which is generally not recommended if they are healthy, unless there's no other vaccine available. And also for pregnant women, we are recommending that they have an alternative vaccine. So I think it's something of an emerging picture. COVID is still a novel virus and it's mutating all the time. We've only been using the vaccines against it since December, and there is ongoing work, rightly, to look not only at the efficacy of those vaccines, but also the safety of them as well. And I think having those safety or mechanisms by which we can report them and the experts can analyze them is a really important part of maintaining public confidence, not just in the COVID program, but in all our vaccination programs.
Thank you. That was a really interesting response there. Brilliant. We've got an anonymous comment, which is we are currently planning to start vaccinating, possibly using the Pfizer vaccine in young people from September. And that leads on to a question that I had when you were talking about the rollout of vaccinations, COVID vaccinations to children with young people with complex needs. I was wondering, is that in the guidance already, or is that something that will happen in the future?
Yeah, so there is guidance in the Green Book on vaccinating people under the age of 16 with severe neurodisabilities who might be in care homes, for example. There is nothing further than that about vaccinating people under the age of 16. This is something that the government will be examining as to the possible benefits or otherwise of vaccinating young people against COVID. But as I say, generally, the younger you are, the less likely you are to be severely affected by COVID. So I think that's probably one of the issues that's going to be central to those thoughts and discussions. And then and what policy we end up with for vaccinating young people. So I think really that I guess my answer is going to have to be summed up in terms of watch this space.
Final question from Heather Godwin. Do you have any advice for breastfeeding mothers who are about to receive the COVID vaccine?
Yeah, there's no evidence to suggest that either inactivated vaccines or live vaccines are a contraindication or even a caution to breastfeeding mothers. So I think my strapline there would have to be, you know, breast is best. Let's continue to encourage breastfeeding, even you know, it's not even including women who've been vaccinated, including the COVID vaccine.
Fantastic. We're just out of time now, so thank you, David. It's an absolute privilege to hear you talk, and thank you very much for giving up your time, because I'm sure you're hugely busy at the minute with everything that's going on in the NHS, so we really do appreciate that. Thank you very much.
Okay. Thank you very much. Cheers.
So we're now going into our lunch break. So there's time to visit the exhibition and the video area. There's the speed networking area, 3 minutes and the opportunity to extend the meeting, meet someone new, or exchange business cards as well. And if we can come back to the sessions area at 12:40 for the panel discussion and closing remarks from this morning's conference. And just to remind you, we have some really esteemed speakers coming for the panel discussion. We have Professor Bernie Carter, Director of Children's Nursing Research Unit at Alderhay Children's NHS Foundation Trust, and the President of the Association of British Paediatric Nurses. And I am sure everyone in the audience has read some of Bernie's research, which has been prolific and really excellently done over the whole of her career. Dr. John Alexander, Paediatric Intensive Care and Respiratory consultant at the University Hospitals of North Midlands NHS Trust, who is also one of the leading lights in the SPOT work around early warning systems in England, and Rachel Bolland, nurse consultant, acute paediatrics, St George's Healthcare NHS Trust. So see you all back here at 12:40 for that interesting session. And again, just to remind you that for that session, you will be able to pose questions. So please start thinking about the questions that you want to ask when you get to that session. And I hope you all have a good lunch break.